So everybody, welcome. I'm very excited to be here. My name is Rina Ramirez. I am the Chief Medical Officer at Zufall Health Center. And as you see here, there's supposed to be a San Wakim with me. He's our dental director who co-authored this presentation and really did a lot of the work for this presentation on our residents of public housing. However, he was not able to be here today, and he's very sincerely sorry. I am so pleased that you're here, though, because I think what we've done here is the beginning of trying to figure out how we can improve access to dental care for our patients in our FQHC as well as those living in public housing specifically. So I want it to be an interactive process. I want you to ask me any questions that come to your mind. Or I'll stop if there's anything that you need to say between. There's like four separate sections on this presentation. I do have the moral support of my CEO, Eva Turbiner, who's sitting right here. So if I am stuck in a question and she can't answer it, then we'll call Sam on his personal cell phone and make sure that he can answer your question. I have his and mine contact information at the back of this presentation. So in this session, we plan to review the dental services in general, the general services that we provide at Zufall Health Center. And we also want to go over a little bit about the relationship between oral health and whole body health. I'm a medical doctor, and of course I like, whole body health, but I think it is important for the buy-in of the provider, the pediatrician, to understand how dental health affects the body. So I think this is a really good integrative process. Overcoming barriers to dental care for patients of public housing. This is what we've tried to address specifically with the special dental services that we provide, and our findings as we study our populations that we've served over the past 4 years since we became a public housing grantee. Now, I'd just like to know who's in the room, who's a dentist. Any dentists here? Good, I'm safe. All right. Any physicians, providers, anything like that? Okay, so I'll try to keep it simple, which is good. No, not too much clinically. Administrators, public housing authority people. Okay, great. Who am I missing? Psychologist, very good. Poor oral health presents a lot of stress to patients, and there's a lot of anxiety and depression associated with that as well. Residents, excellent. And you know the challenges that it is to try to get to your dentist and to try to get the care that you need. So that's wonderful. Okay. All right. So, yes.
Okay, you just answered it. Okay, where is?
Exactly. I'm going to go with Sioux Falls. It's not Sioux Falls, which is the big one, right? It's like there's a Sioux Falls somewhere that we always think that we're in New Jersey. And we're a health center located in northwest New Jersey. It's a suburban, semi-rural area of New Jersey. And we were established in 1990 in Dover, New Jersey, started by Dr. Zufall, and that's why the name, as a volunteer clinic with him and his wife. They saw the need in the area in their own backyard. They had actually gone out to Peru and had done some volunteer work for people in that country, and then said, we don't have to even go that far. So when they retired, they actually set up a one-room center in a basement in the church in Dover, and were able to get volunteer physicians to help them work with and provide free services to the residents and the immigrants in that community. It was a very largely Puerto Rican and Hispanic immigrant community that has evolved over time. And as it grew and became more and more known, it actually became an HQHC in 2004. But I think even before then, he had volunteer dentists and had a dental chair or two. Through a Delta Dental, I think, grant, so that he was able to provide dental services to patients who didn't have insurance. We expanded to 3 sites, and one of the sites is in Morristown, which is also in Morris County. And that's the one that we got the first designation for public housing in 2009. And we also have a mobile van that provides medical services, and that we've been using that medical mobile van to provide access to services throughout the counties because we serve 4. So this has been a really useful tool for us and a good service to incorporate into both medical and dental. We have been serving uninsured, underinsured. We also have a homeless we serve the homeless. We have a special POPs for the homeless. We serve residents of public housing and farm workers. So we have all the special POPs, and we really try to provide everything that we can possibly in order to give primary medical services, primary dental services, and a little bit more. We provide behavioral health services. And we provide enabling services just like other FQHCs do. We do not provide prenatal care yet. That's done through the hospitals that we partner with. So, as other health centers, we have a whole slew of programs, including the Ryan White program, Part A and C. We have enabling services, including patient navigators and case managers or people to help people navigate them through systems. We are participant in the Reach Out and Read, are very interested and involved in health literacy promotion and other things. So I'm sure I'm missing a million. If there's anything you want to interject. We are open 7 days a week. In the Dover site, we're open on Sundays, and that's been a real plus in terms of access. In 2012, this is our UDS data, we served over 16,000 patients. When we started, how many patients do we have? 3,000 7 years ago or 6 years ago. So we've really grown like many other FQHCs around the nation because of all the opportunities and also the need that we've been seeing with the advent of unemployment and uninsured patients. 94% of our patients are below the poverty level, and 72% of our patients have no medical or dental insurance. That's a big issue for us, for sustainability, for programs, and for trying to make things available to our patients. So this is something that I think it's not the norm in FQHCs, because a lot of FQHCs do have a large portion of Medicaid patients and other insurers. What we do have is a special program in New Jersey that allows us to get paid, compensated for helping and taking care of the uninsured in the state. We also have a lot of new immigrants in our community health centers. Many of them Hispanic, or the majority of them Hispanic. So that's why you have that ethnic, racial minority group. Over 50% of our patients are best served in a language other than English, and mostly Spanish, and therefore our staff is bilingual in Spanish and English so that we can really try to communicate with them in the language that they understand. And we serve mostly adults. We have a smaller but hopefully growing population of children, and we have seniors, and we love our seniors. And you see the percentage of uninsured, including 48% of children uninsured. They're probably not eligible for insurance because they were brought in by their parents or by their family. So this is just a reality, and we don't know how the ACA is going to help us with that. 540 of those are patients of public housing this year. Okay? You get a pretty clear picture of where we are and what we do? Okay. All right. Stop me at any time. Now, Dr. Wakim wanted me to brag about, or he wanted to brag about, the 4,200 patients that he's seen in dental. That's also been a very incredibly growing service, with 10,000 visits in 2012, and with 150 children between the years of 0 and 3. Now, I wonder why he put that in there, but I think this is one of the biggest points that we have to think about. Prevention, prevention, prevention. Education, education, education. If we educate the parents of children at 1 year old to bring their children to dentists and to begin the fluoridation and the proper care of the teeth, we can prevent so many other horrific stuff that's happening later on in terms of dental problems. So this is why he's very proud that he started to provide services to infants. And this is a very important target population, as well as children. And then, of course, as adults, we need to, we need to take care of ourselves again also. In addition, we have a sizable number of seniors, and I'll show you why in terms of our public housing mix. So again, a range of dental services, screenings and cleanings, using the sites, and I'll go into the different service areas that we do, into the actual fixed sites, using the mobile van, going to the schools. We also have expanded our dental staff to include those who are good with kids, because dental appointments and dental visits with children are very important to be positive so that we can continue to have that ongoing relationship throughout life. Also with geriatric issues. And so we're trying to really look at what it is that our patients need, who our patients are, and provide the services for them, given the right staff. And there's definitely a lot of education on preventive services that all FQHCs do, like give kids a smile. If you're in FQHCs, you know what that is, a big program every year, and National Rural Health Day. So we're involved in all the other things that community health centers do. Okay? This is the public health approach to dental. And the biggest of the pyramid, and the biggest part that he wanted to point out to you, is that this is the part that we really were going to be, if we don't get behind this, if we don't do something at the preventive services level, we're behind the 8 ball in terms of oral health for all, not just for residents of public housing, but for all. So we focused a lot on preventive services at our center, including the school-based fluoride rinse program, school-based programs, and sending the van out to help provide preventive services before the oral disease sets in and starts creating all sorts of other problems. So what this means is that if you fluoridate appropriately and you continue to give fluoride in the right way to the right people, you will then prevent oral health or oral disease in between 30 to 50% of the people that you will then find up in the pyramid up here with more problems, with restorative problems, with preventive stuff, with cleaning, with extractions, which is what really I find that the majority of our patients are having to do. They've gotten through the let's prevent oral disease to, we're in the, let's do something about it. We have to start treating it. We have to start rooting and planing. Let me just tell you, I was a dental director kind of for 2 years, so I sort of learned a little bit about dental, so it's okay. So I can talk a little bit about that. But this is where a lot of the health centers spend a lot of their time in. And we really want to also fix it down to this, because if we do this, we can avoid a lot of that. Okay? Everybody with me? All right. And our public housing sites, this is just a listing. What we've done is we're a community health center, so we provide services at our site. We're not in a public housing, we're not co-located in public housing at this point, but we're close enough to the public housing larger buildings in Morristown and other areas so that patients can come to us. However, because of the makeup of our public housing population, we have a large number of senior housing. And some of them are not that close to our center. So what the dental strategy has been is to go out to the public housing sites, with the mobile van, make appointments, make prearrangements to go out to them, because if they cannot get to our fixed site, then we have to go out to them. And this is what I'm going to go a little bit into later on how it's worked. All right, so this is a mix of family public housing as well as senior public housing. Plus there's a lot of voucher housing, which is, and it's, as you know, it's always a challenge to identify the patients who live in public housing, especially if they're not specifically in a big building. So we're always looking at that. We're always taking care of everyone, regardless of where they are, but we want to make sure we provide these services to residents of public housing. All right.
Rina, let me just
Sure.
mention, this is something, because we are located in the suburban area, I think this is a trend more and more, is to have small complexes scattered throughout, larger communities.
Yeah.
And while that may have benefits in terms of integration into community and schools and such, it does create a problem for identifying and reaching those folks who are not in one large project.
Right. And you got to strategize, because then if you are in a situation where you just don't have one large project, you got to figure out how to identify and then how to spread yourself, not thin, but spread yourself so that you can actually go and help the patients. Because of the high number of senior public housing that we have in our county, this has been a very interesting experience for us, and we've tried to, that's why we have a gerontologist, somebody who really knows how to take care of senior issues in our center. So you have to take a look at what you're doing in your site, what the needs are in your public housing site, what are the needs are in your community health center, so that you can then figure out how to best serve that community. Should you go there? Should you bring them in? That kind of thing, right? I'm going to go very briefly into this. This is the sort of the pathophysiology disease state process of oral health and oral disease and how it affects whole body health. But there's some things that are preventable right away, and you can see them right there. Smoking, alcohol use, excess sugar consumption. Those are preventable things, because people, if they do this, they will then develop a higher incidence of oral disease. Whether it's cavities, there's gingivitis, inflammation of the gums, or even more severe things like periodontal disease, which is inflammation of the gums and the bone. And that's where you don't want to be, okay? So there are solutions. There's smoking cessation, don't do it, you eat a healthy diet, you can have some rehab services to try to get you off alcohol, so that there are things that you can prevent both in general health and well-being for your body, as well as will also affect your oral health. Accidents and injuries in the elderly, very important. They fall, they hurt themselves, they can break a tooth. That could just set up a whole bunch of problems. Night lights are good. For children, sports, very, very common reason to have trauma to the mouth and other places, and so mouth guards. And then there are other things that are not as manageable, like genetics. And so some people are more susceptible to dental problems than others, to gingivitis and others, and maybe even medical conditions like a pregnancy. Pregnancy also sets up for a little bit of a more susceptibility to inflammation and I'll talk about that in a minute, to inflammation in the mouth. So there are some things that we can't do anything about, but we have to be aware, so we can then go ahead and get good oral hygiene. And I'm going to go really briefly in the importance of chronic inflammation. Chronic inflammation is when the body sets up its own defense systems in order to ward off infection. And of course, the mouth is one of the most, there's other places, but one of the most bacteria-laden places in your body. And that sets up, that's a natural place where it could definitely begin to, you can have chronic inflammation going on throughout the body. It's not just in the mouth. There's chronic inflammation associated with chronic conditions, and I've listed them here, including arthritis, pneumonitis, and some connective tissue disease, which is like the rheumatoid arthritis and other things that, just make people feel bad. And it's usually an ongoing inflammatory attack on different parts of the body. And in addition to that, because there are so many bacteria in your body, bacteria can get into your bloodstream and can cause things like heart disease or heart inflammation and infection of the muscle of the heart, abscesses, and other things. So again, the portal, which is your mouth, can pretty much stay nice and stable, doesn't infect your body, unless there is a lot of inflammation, there's a lot of poor oral health going on, and then the inflammation will set in, and then your body can be affected by poor teeth, by abscesses in your teeth, by gingivitis or periodontal disease. That's what I'm getting at. That there is a correlation, there is an association between oral health, inflammation, and your well-being. Okay, so this is just a little bit of a description of how inflammation works. The bacteria in your mouth form a biofilm. That biofilm then traps some bacteria in there that continue to replicate. And there, they will then begin to release some inflammatory things called cytokines, or things that go throughout your blood system and your entire blood, to your organs. And it sets up this assault to your whole, to different parts of your body. So it is important to keep, to floss, to keep, to brush, to keep your mouth as stable, steady state as you can, because these substances have been associated with ongoing disease, with other things that I'm going to talk about really quickly. Things like heart disease. This was something that was found about 10 years ago or so, the correlation between poor oral health and heart disease. And how at that point it became very, very clear that if you had regular dental cleanings, a little substance, that sort of inflammatory substance that get released in the body called C-reactive protein would go down. So it says, oh my gosh, how to take care of my heart, I have to go to the dentist. That's very interesting, but I think that that's something that we all have to remember as individuals, and that physicians also have to remember to help their patients and send them to the dentist. So again, this is C-reactive protein. It's an inflammatory response to the germs and the oral bacteria that are getting, they're flourishing because of a good environment in your mouth. That is, that you're not taking care of your teeth. This is just an ugly thing that he wants me to put up. All right. Oral health has also been, this is not proven, but they've been associated. You've seen correlations between poor oral health and the risk of having preterm labor and low birth weight babies. So again, it is, due to an inflammatory response. They think that the bacteria actually goes into the womb through the placenta and affects the baby. And therefore, it sets up for a negative impact on that outcome, right? So they've seen, several studies have shown that preterm incidence of birth incidence has been 10% in patients with periodontal disease, as opposed to those who don't, who have regular dental care. I guess this thing didn't work. Okay. And finally, diabetics. Diabetics have a risk for developing poor oral health because they have a very friendly environment in their bodies and their mouth for bacteria. Bacteria love sugar. They ferment the sugar. They make it into acids that erode the teeth and then develop a terrible cascade to begin that chronic inflammation. So what they found is that, and in addition, because a lot of patients with diabetes also tend to get bigger and bigger, so there's associated with that another causative factor to developing inflammatory response, which is obesity. Fat cells also release those little cytokines that I was talking about. So what we found, and we routinely recommend, is that our patients with diabetes go to the dentist every 6 months to get a cleaning. It helps in controlling their sugars. If they're not controlled, if they have an infection in the mouth, their sugars are going to go up. So it's, again, you see the correlation? Yes?
I am diabetes myself. Do you know it's been about 5 years and I still can't get an appointment?
Oh my God.
I've lost 2 teeth since then. We know how to take care of our teeth.
It's the access.
Exactly.
I mean, that's terrible.
How come they don't take, they'll take, a month will do it, but years?
Years, no, that's not acceptable.
At 7 o'clock in the morning.
And you can't get in.
Exactly. But then I have 2 toothaches.
Mm-hmm. Well, emergency, but that's not what you want to do. You want to prevent. You want to, exactly. I know, and there's a problem. We're working on it. We can't get to 100%, but these are some of the ideas that we have, that we tried to do to reach out to our patients. There's been associated with pneumonia and oral health and bad oral health, especially in patients who are in nursing homes, who are elderly, who don't have a good cannot secure their airway so they can just breathe in the oral bacteria. That happens also with patients who have alcoholism, seizures. So there's other correlations between oral health and poor oral health and disease here. And finally, osteoporosis. This is one of our ladies, and she's just lovely, and she comes to the van all the time. And she has osteoporosis, but her teeth are, she's okay. But essentially, there has been a correlation between osteoporosis and alveolar, which is the bone loss in your teeth. Like dentists sometimes can tell from looking at your mouth if you have a medical problem. And they see that the bone is a little bit loose, and they say, oh my gosh, she has osteoporosis. So they've seen the association between the two of those things. So it's one or the other, right? So obviously, medical and dental have to collaborate because it affects the mouth, affects the body. And if we can take care of the mouth, then hopefully the body will get better too. And that's what we want to do. One of the things that we do is we work a lot with our pediatricians and our primary care providers. And we provide trainings, we provide tools like the Project PEDS program. Project PEDS program is a New Jersey Department of State program called Pediatrician Preventing Early Dental Disease. And what that does is that it gives us little kits to give our pediatricians to give the parents of the children who come in, even as young as 1 or younger, to begin to take care of the teeth or their little gums, to begin to educate the parent that is so important for the child to start as early as they can to take care of their mouths. And also to tell the parents, they got to take care of their mouths. As they kiss the baby, that bacteria is going to the baby. So they got to take care. It's just normal. It's fine. That they need to take care of themselves so that their kids will have good oral health, okay? And again, addressing common risk factors. The dental program and medical had a very successful, I forgot to put this in here, successful program together last year working on a healthy weight with our children. We had a no sugar campaign. And Sam said, this is the best thing because I always tell the kids no sugar. Sugar sets up the cavities for the kids. That's how you start. If you eat something sweet or anything that will ferment in your mouth and begin to develop the right conditions to weaken your teeth, and you develop cavities. So he's a no sugar freak. And he tells the kids to please brush your teeth every time you eat and do those fluoride washes. So that's a great collaboration on healthy weight, no sugar, medical, dental. The other thing that we've done is we've provided courses for on fluoride and fluoride use and the good things about fluoride to both dental and non-dentists and pediatricians in our state. We do it together, and so that it gives push and substance to that we're trying to do this integratively between dental and medical. So it's a very important thing to get the word out to the primary care community. What are the challenges? You know them already. Access to care, transportation, unmet dental needs. There's just too many people who need dental care, and there's not enough dental services that are affordable or accessible. And case management and outreach. People don't know about the services. People cannot follow up, and I'll go into it deeply. This is just an article, and that tells me something that reminds me, our patients, our kids, low-income kids do have CHIP. They covered for dental, and so, but we find that many kids don't come. to the dentist. They come only when there's pain, when there's an abscess, when there's an emergency, not for routine care. And it's a thing that we want to begin to turn around. And all of us are working on that.
And sometimes it's the mothers.
Exactly. The mothers can make it, or it's not a priority for them. It's not on the top of their mind, or they want to silence the baby, or they know they're too busy that they put the baby with the bottle like this, and leave the bottle against the teeth, and that's you get bottle mouth, and it's a terrible thing. It's a lot of different things. So there's a lot of education that has to go on. Yes.
I'm sorry, I don't know this, but in New Jersey, is there an adult dental benefit for Medicaid?
Yes. Yes, it's wonderful. I think so.
Washington State used to have it.
And the other thing New Jersey has, just to say, is that the charity care program for the uninsured also covers dental.
Yes,
So
we're
that,
very lucky.
There's a higher copay, and it covers a little bit less, but frankly, even uninsured adults can get affordable dental care.
Right. We do have sliding fees, and we put all that in effect. But this is a very important, and that's one of the things that we need to do is advocacy for these kinds of programs and services to be covered. Because again, they're preventive. They prevent worsening of disease. It's a good feeling to have good teeth and not pain, and it is important.
In Colorado, under the Medicaid system, there's two basic plans. One for the children, which is excellent. Get
Yes.
the kids in there every 6 months.
Good.
Checked out, everything. For the adults, there's one thing, extraction. Through the emergency room, and that's it.
Terrible. Extractions, when I first started, when I was dental director, and I saw the x-rays and I saw all the extractions, I was just going out of my mind. Because that's the last resort.
At that point in time,
Exactly. So we don't want to get there. We want to move that curve over, that needle back to the preventive, that pyramid, down to the, okay. So this is, just so that you see where we are. This is New Jersey, sort of like a bad, and then we're up here in those 4 little stars up there. So it's the northwest corner of New Jersey. Newark is here. Trenton is here. No. Yeah. Well, that's Camden. Oh, yeah, Trenton. Yeah, Trenton's here. Okay? So we're sort of like in the corner up there. But we found need. We found people who need our services. Obviously, we're there and we're thriving. So we have, what are we going to do? So we have to provide more dental sites, more dental doctors. We've expanded the team. We're expanding to 2 new sites. We've expanded. The 2012 data was on 4 operatories. In our Dover site alone, we were able to expand to 6 operatories in that site. Plus, we have 2 in Morristown, so that's 8. And we're going to begin to have other sites that have dental. So this is really exciting for us. And again, because of the pay or availability of being able to sustain some of our programs, we do this. We do provide affordable care using sliding fees, Medicaid coverage. We also have grant-supported services. We write grants all the time. We provide free services if we can, and special POPs, because we know how important it is. Okay? This is our fixed dental site, and this is one of the 4 ways of doing this. Fixed dental site, that's our Dover site. We're very proud of it. It's just a brand new facility. And so the fixed dental site is the traditional site. You come to your center, you have your dentist there, the doctors are, in our case, just next door or even in the same building. So there are very good benefits to this. Oops, what happened to it? Okay. The benefits are that it is more, wait a minute, I think I have the wrong slide. Well, it's okay. There's more, it's a higher startup cost, okay? You treat more, the benefits are that you treat more patients, you provide more extensive services. There's a higher startup cost, though. That's the bad thing about it. And operating costs are also ongoing. So, there are good things and bad things, but here's where you can do the extractions if you have to. You can do a lot of the cavities. You can do the dentures fittings. You can do all sorts of the really big, heavy work, plus do the referral, sent to oral surgery, that kind of thing. It is a costly endeavor, as Eva will tell you, but again, very needed, and there's a lot of different ways that we can support this, including the patient paying. I mean, sometimes that has to happen. There is a lot of staffing requirement as well. There's clerical support, that kind of thing. For the portable dental program, this is another way that we've done it, is actually to take our operations to a central location somewhere in the center of town, or in a location where that can give us space and and the facilities to be able to set up portable equipment and be able to provide services. In here, this is a county college out in Warren County, where it's a very rural area, so we had a big thing. People would come and get their free dental care there. This is a Head Start program using a little chair and putting a sealant. So you need to have these kind of creative things to be able to get to the patients where they are at. So that's a portable dental program. That is a little bit, you can still have good care with the patient, but it is very, very physically demanding. You have to take all the stuff in with you. You have to, you have to set up and break down. You have to do all sorts of things in order to do this, and you don't get as many patients as you would like. It's not a true medical home by any means, and what we do is it's ground funded because it's not reimbursable when we do this. Okay. This is portable dental equipment. That's our suction. It's about, a few $100s. And this is our portable chair and the little boy. So, we are able to actually have equipment to go out to the patients where they're at. Okay? Transportation. If you cannot get to us, we will get to you. This is a full mobile medical van. It's medical, it's not dental, although a lot of health centers do have dental vans, and it's something that, would be wonderful. But we're making do with our medical van, and what it does is that it provides the ability for us to go to those public housing sites that I showed you. We make appointments and go there with our portable equipment and are able to actually do x-rays using a portable x-ray, do cleanings, put sealants on, screenings, and do actual denture adjustments. So you can actually do a lot of stuff at the sites. And so that you go to the public housing areas and really just line them up, get them in. These are some of the staff. We have disposable supplies, our digital x-rays, sensors, that kind of thing. And what's good about this is that even though, we have our medical van, we use it for medical, but we can also, our staff is very flexible in finding other creative ways of using the van. And it's licensed, and we can get reimbursed by the state through it. So again, you got to figure out creative, different ways of getting to the patients if they can't get to you. And that also opens access, because then, you have three dentists in one site, and you have another one working with you at the public housing area, and at least to begin your treatment. And then at that point, you can then set up a follow-up appointment into the fixed site, so that you can get more significant treatment if you need to.
So this is what you're trying to do, is get these vans in Colorado?
No, this is what's worked for us. If there's an FQHC in Colorado that wants to do this and uses it as an idea for them, that'd be great. And I don't know if there's an FQHC in Colorado. Yeah.
We have a mobile dental van in Alabama, actually.
Mm-hmm. 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 Yeah. So it's just an idea. I mean, I'm trying to see if others who provide services are here, or you can tell, someone, is this something that we can do in order to have more dental services where I am?
Eva and I are from the same place. I'm the patient navigator at Trapeze, and the proposal is down the street, and Eva is part of our leadership. And I think she and I did not talk about this, but we're kind of in the room, I think, for the same reason. We're trying to figure out how we can get our residents into dental care.
Mm-hmm.
And so I think that's why we showed up.
Yeah.
And it's great to hear what they're doing in New Jersey, but that's not going to help our teeth in Colorado. So I'm disappointed there are no providers in the room who are dentists and stuff, because this is great.
This is for them.
This is for them.
Or maybe for the administrators.
It's not going to help me save the rest of her teeth.
Right.
Or get my other 100 and something people into dental
right.
care. And that's kind of why I think we're both here, why I believe you're asking these questions.
Yeah.
How can we get our people who don't have the co-pays, who do have Medicaid and Medicare, to save their teeth?
Right. Well, as a patient navigator, you have some connection with your community health center. You know people. You don't know people.
I've been trying to get people in since February.
Okay. So there's an access issue, definitely.
And the date is January. Wow. No, July.
July.
And then I have to call at 1 o'clock, and my history is showing I have to hang on the phone for 45 minutes to finally get in to talk to someone, and then I can only book one person at a time. And I've got at least 10 people who want to see a dentist.
Mm-hmm. Yeah, I mean, this is the solution that I can bring to you in terms of what's worked for us. And what I'm hoping is that either you take it back to someone that you know could maybe begin to make the decisions to do the grant funding, to do the, some of the programmatic changes, to be able to use other creative ways of expanding access.
I mean, I understand.
Yeah.
I realize that you're talking about.
I know. I can know what I do.
I mean, I think from the federal perspective, we kept hoping that some of the Affordable Care Act dollars was going to be released by HRSA as an oral health initiative. There was a lot of chatter about that some of the ACA funding would come down of, 330 funding for expansion of oral health.
Unfortunately, that doesn't seem to have happened. I don't know if it's going to happen. It looks like they released the Affordable Care Act money for outreach and enrollment into health insurance instead, which once again will help kids. There's more and more dental services for children, at least the adults out in the cold. And I guess we're particularly fortunate in New Jersey, and I know in New York the same. There's a lot of coverage, but maybe there's a political discussion. I mean, I think some of the things that we see about the relationship between oral health and medical health, the relationship between how many emergency room visits are for really issues around oral health. I mean, maybe that's the kind of advocacy that your leadership needs to start talking about.
Exactly. Exactly. Yes, exactly. So yeah, I am sorry to disappoint in that sense, but I'm trying to give you maybe some kernels of ideas to bring back to your leadership, to a person who would listen and say, there are other ways that we can do this, and maybe perhaps even in a cost-effective way, because eventually it will save it will save the system. Now with the ACA and the and the Medicaid expansion and the exchanges, I understand that it's always very state specific in terms of what's going to happen, but we're advocating for dental coverage in all the Medicaid programs. We have to, and we bring it up at whenever any Medicaid person comes in with their exchange program, I say, what about dental? You have to, because it's so part of medical. Yes.
It seems like a huge dental shortages of dentists.
Yes.
So we just don't have the capacity to care for people.
Right.
And I know in Massachusetts there's been a move to have primary care physicians able to apply
yes.
fluoride bars
yes.
in a medical visits.
Yes.
And I'm wondering if that's
Yes.
going on in Jersey.
We have talked about it, and we have been at the cusp of doing it. We are lucky in that we have a lot of dentists, and therefore we don't have to have our pediatricians do it. But it is certainly a good model, because if you go to the bottom of the pyramid and help those kids get those fluoride treatments at the appropriate dose at the appropriate time, you will prevent the extractions and the extent of the tooth decay later on. So yes, that's another good way of doing it. New Jersey just recently passed, liberalized at least the duties of a dental hygienist. And so that's another way of doing it. As we're using in primary care, we're using nurse practitioners. Maybe there's a dental extender in that sense that could actually help do some of those cleanings and provide, narrow the gap a little bit or close the gap a little bit in terms of the provider shortage. I agree with you.
It used to be that hygienists could only work when the dentist was in the building. And now they've liberalized that a hygienist is able to work under the general supervision of the dentist doesn't have
Right.
to literally be at the same site.
So again, a lot of advocacy in that sense, perhaps from the industry and the groups, the medical groups or the dental groups, to say, let's try to expand the services by having people who can actually help dentists, but not necessarily be dentists, under their supervision, do some of the basic work. Another idea. Right? So these are the pros and cons. I have the right slide deck now. These are the pros and cons. And one of the things that we found has been interesting is parking is hard when you have a huge van, and the weather out in New Jersey with the hills sometimes can be a little bit of a challenge. But otherwise, we're doing pretty good with our van, and we're very proud of that, because it was something that we didn't foresee we would be using it for, and it's been really helpful. The other things, the unmet needs, other than having more dentists, more dental staff, we talked about education, sealants. You beat me to it. Fluoride, making sure that the kids and adults have the right tools in order to protect their teeth, get regular exams and cleanings. We know that, and we want to be able to provide this in as best way and as affordable as we can. Two things that have really helped us is the outreach and having patient navigators like the gentleman, who was really good, because you got to establish the relationships. You got to say, I have a program that I think that could benefit your residents. I have a program that I think we could bring it to you. We can work together. And so having an outreach, and we have an outreach program that we have. So we have three staff. And each one they're supposed to outreach everything, but each one is designated for one of our special pops. And here's Marvi doing she's the public housing. So it's great because she pre-registers, she coordinates the visit, she, provides the information about what services we are, and she's there helping the patients, trying to get on the van or trying to get them in, making those scheduled appointments, and the van goes out and meets them. And we see 20 patients. We see 25 patients, which is pretty good. And then obviously follow-up, important for referrals, for making sure that a patient who has a broken appointment comes back. And so it's, it's a combination of that. That's our responsibility. So case management is important. Any other discussions on our program specifically and all the different components? Because now I want to show you a little bit of what we found with our patients in public housing in our population. And we're beginning to take a look at it really closely, because we want to make sure we begin to have the data and the information to make a compelling argument to the funders and the government that this is a problem that they need to help us fix and give us funds to do it, right? So essentially, since we started January 2010, even though we started a little bit earlier than that, but we looked at our total population of patients who had been seen in our centers since we became a public housing grantee, and it's 970. We've had 424 dental patients and 1,500 dental visits, and 44% of our patients in public housing have had at least one dental visit. Now, I'm very proud of that. because I know that this is a big barrier. And this is something that I really wanted to share with you, because this is with going out to them, engaging them, making sure that we can, be there and provide some services. We've had, of those, 59% have come back for a follow-up visit, which is wonderful, because then they were able to make it to our fixed sites, and that's good. A lot of it is word of mouth. People don't know about our services, so you need to be out there, and so that's the good interrelationship with outreach and with dental and with medical, referring to dental. It's just slowly but surely. And 58 of our children had at least one visit. So we're really working. I mean, it's not as high as the general population in New Jersey. In New Jersey, people do go to the dentist, at least 76% of them. So we're getting there. Still not great, but we're getting there. And this is just a little breakdown on the age and the populations, the adults. We have a lot of seniors using our van and our services for dental. We're very proud of that. Most of them are women. Most of them are English speaking. And this is one of our seniors and one of our students in the dental van. Yes.
Your health center does all the special populations and its regular activities.
Yes.
Yeah. So I'm wondering, among the CHC, the migrant, the homeless, the public housing areas, where do you see access being the lowest?
Migrant. Oh, yeah. First of all, we're a new grantee for migrant, and there are a lot of challenges to get to those farms. Our outreach program is the director of the outreach program, plus one of the outreach workers is working on migrants, because it's just so hard. You got to get the farmers to trust us to let our van. We just went to the van last week to one farm, and we had a good turnout. We're excited. The van really helps with that. Okay. And this is our breakdown. You see this in the UDS, essentially, but most of them are Hispanic, 48, half and half, I guess. And those are little kids. And what we did is we actually did a retrospective chart review. We wanted to see what we were seeing. We wanted to put it down on paper, and we did a sample size of 217 of our patients throughout the whole entire work of the public housing experience that we've had, stratified random by age group, and to try to get a confidence interval of 95%. This is my Dr. Wakim's master's in public health speaking right now. He wants to get it. He wants to try to figure out something that we can then move forward with. We had a independent review board review it. And essentially, it is as all the patient identifiers are not in here, so it's almost like an exempt situation. What I needed to do, obviously, is to see what the medical conditions were, and I was very, very. We did not do a tremendous job of trying to get all the medical conditions for our patients. We were really there for dental, but I just wanted to take a look and see about how our patients were doing, and for hypertension, and for anxiety, depression, hypothyroidism, and COPD, and asthma, we were like around the same as has been reported in public housing overall. We're a little bit lower on cholesterol. People don't know they have high cholesterol. They don't feel it. And we were much higher in diabetes than in the New Jersey general population of seniors, actually. It was 21% of patients, of seniors in New Jersey have diabetes, and our patients had much more than that. So that was an interesting one. As you mentioned, as a psychologist here, the anxiety depression is very high, but it is prevalent in public housing throughout. So this does not mean too much. I was just curious. I did it for me, but I think it's important to begin to take a look at what we're seeing, so that we can then make a compelling argument that this is what we need to have. But this one is the actual findings on the dental visits that we had. And I really want to bring to your attention the untreated decay In children, adults, and seniors, overall 71%, at least one tooth is decayed. And look at this, according to the National Health and Nutrition Evaluation Service. It's just such an incredible difference and such a disparity there. So oral health is including and physical health. There's a disparity in our populations, especially in public in this group in public housing. So 3 or 4 times greater rates of decay in teeth. In periodontal disease, which is the more advanced disease that goes into the bones and then can get into the inflammation and into the body, is significant, 8% versus 39%. That's 4 times high. The same thing with seniors. Edentulous was not so different, but it was still a little bit higher in our population than in the general population in New Jersey. This is the New Jersey Behavior Risk Factors Surveillance. But it's a CDC program, and it actually gives you good data on what's happening in New Jersey. So edentulous means, dentures. So this is very significant, and I think we can begin to do some advocacy work when we see this and say there is truly a need. We know it, but we need to show some, figures and some data, right? So what are conclusions? It's obvious. We have a need. We had 2 representatives here that were telling me that they don't have access. So obviously there's a need. There's higher rates of decay and more significant disease in our patient population that we studied. They're less likely to go to the dentist than the general population for many reasons, like the lady mentioned. Cultural, financial, lack of access, lack of affordability, everything. It all comes into play. Educational. I thought that they did have a higher incidence of anxiety and depression, but I think it evens out in terms of the patient population in general in public housing. But they do respond, they do come, and they do go to follow-ups if it's available. We just have to make it available. It's our job to make this available, and also to prevent it from getting so bad. And so we have our periodontist showing a big tooth. I don't know why she's not scared. It looks like Jaws. And our tooth fairy teaching a little boy how to brush his teeth. You got to do these things so that the kids apply it in a positive way and want to, go to the dentist without fear. All right. What are plans? Again, which we are fortunate, and we are increasing access, as I mentioned. And we want to expand to other areas to be able to provide services where they're needed. And we know that we're needed. People are clamoring for dental services all across the nation, as well as New Jersey. We are also continuing our integration with primary care providers and using all our services to bring to mind to our patients the importance of dental and oral health. We talked about the sealant program, and Eva and I will strategize and figure out how we're going to do that if we need to. Have pediatric dentists. We're lucky in that sense. And again, early education. The dental team goes to Head Start. The dental team goes to the schools. He has a good relationship with the school nurses. He goes around he doesn't pull the kids out of class. He tries to do everything at once so that it's not a big nuisance. So, you got to work around it. We have late hours at the center. People need to come out. We have Saturday hours at the center. We haven't opened Sunday yet, but for dental. But, if there's work, people who need it, we'll try to accommodate it. So you need to find and advocate for that so that your community health center provides this for you. We're also participating in county and statewide educational initiatives and trying to go to the schools to teach the nurses and to teach the teachers and to teach the parents about early oral health care for the kids. Again, looking at that bottom of the pyramid to try to prevent all the unfortunate things that happen later on. All right. And finally, we really do want to continue to look into getting good data on what we're seeing, because we're scientists, and we also like to be able to advocate in a very strong way that this is a need that is very important, it's unmet, but we can do something about it. So I'm sure there are other things that you can think of here. And this is our dental team, some of them anyway, with the tooth fairy in the middle, who happens to be our director of outreach. You know, she just gets put into many different, this is like staff, retraining. But no, she's good. And these are some of the references that I used, including the National Health and Nutrition Examination Survey. It's very good data if you can get on the website, as well as the Behavioral Risk Factor Surveillance System. And that's by state, but CDC run. So you can see what's happening in your state. So if Colorado has umpteen thousand% of patients who have, tooth decay, they know it. You got to tell them, look, what are you going to do about it? And there are other things here. And this is our contact information as promised. So you can call us. You can definitely call Dr. Wakim. He'll be more than glad to describe any details of the program on how it could be even done in Colorado or anywhere else. So please do not hesitate to send him an email or give him a call, because maybe there's a way that we can go nationally and talk to people about it and say, dental directors, get your act together. Let's do this. And that's it for me.